Hello everyone, welcome to Let's Learn Patho. The topic we are going to discuss in this video is pancreatic neuroendocrine tumors, that is, in short known as PanNETs. So, as we all know, pancreas is a heterocrine gland. That means it includes both the endocrine portion, that is islet of Langerhans, and the exocrine portion, that is pancreatic acyni. So, the tumor of islet of Langerhans is known as pancreatic neuroendocrine tumors, and there are different types of pancreatic neuroendocrine tumors depending upon the type of cell involved. Like the tumor of alpha cell is known as glucagonoma, the tumor of beta cell is known as insulinoma, and the tumor of delta cells are known as somatostatinoma. So, out of all these, insulinoma is the most common type of PanNET, and we will discuss insulinoma in detail. But before starting insulinoma, let's discuss a bit about the pathogenesis of pancreatic neuroendocrine tumors. So basically, there is alteration in three major genes or pathways which is responsible for development of pancreatic neuroendocrine tumors. The first one is mutation in MEN1 tumor suppressor gene. Now, mutation in MEN1 tumor suppressor gene is responsible for development of familial multiple endocrine neoplasia syndrome type 1, and as a component of this syndrome is pancreatic neuroendocrine tumors like insulinoma and Zollinger-Ellison syndrome. Then mutation in P10 tumor suppressor gene is responsible for activation of mTOR signaling pathway, and being an oncogenic pathway, the activation of this pathway will be responsible for development of various PanNETs. And thirdly, the mutation in ATRX and DAAXX gene will cause alternate lengthening of telomeres, maintaining the length of telomere in the neoplastic cells, providing them limitless replication potential and causing the development of pancreatic neuroendocrine tumors. So this is all about the pathogenesis. Now let's start our discussion of insulinoma. So basically, insulinoma is a tumor of beta cells of pancreatic islets, and it is most common type of pancreatic neuroendocrine tumor or PanNET. So basically what happens in insulinoma is there is excessive production of insulin. So the talking about the clinical features, the main presenting complaint of the patient will be hypoglycemia, and the attacks of hypoglycemia will precipitate as a result of fasting or exercise. So what will be the symptoms of hypoglycemia? The common symptoms of hypoglycemia includes sweating, palpitations. Then the patient will be irritable or anxious. He will feel more hungry. He will feel fatigued, and there will be a lack of concentration, right? And he will also be pale. So these are the common symptoms of hypoglycemia. But these symptoms are like very vague, right? There can be some conditions which can mimic the symptoms of hypoglycemia, right? So there is a triad called as Whipple's triad, which is used to differentiate hypoglycemia from the conditions which can mimic hypoglycemia. So in the Whipple's triad, there are three things. First of all, there should be symptoms of hypoglycemia, which we already discussed, and these symptoms should get relief after administration of glucose or after eating food, right? And the blood glucose level of the patient should be below 50 milligram per deciliter at the time of attack. So this makes the diagnosis of hypoglycemia. Now coming to morphological features of insulinoma. First, let's start with the gross features. So on gross examination, the insulinoma will look like a small encapsulated pale to brown nodule. It can be multiple in number, but mostly it will be solitary, right? And talking about the location, it can be pancreatic as well as extrapancreatic in location, but extrapancreatic ones are very rare. 99% of insulinomas are located in the pancreas itself, and they can be located anywhere in the pancreas, in the head of pancreas, neck of pancreas, or even in the tail of pancreas. Then coming to microscopic features. So as the insulinomas are mostly benign in nature, right? So the neoplastic cells present in insulinomas, they will exhibit minimal pleomorphism and minimal mitotic activities. And the neoplastic cells are well differentiated. That means they will resemble the original beta cells of the pancreas. And these neoplastic cells are arranged in the form of cords or sheets. And another characteristic feature which is seen in case of insulinoma is abundant amyloid deposition. So you can see in this diagram, there is cord and sheets of cells, and there is abundant eosinophilic amyloid deposition, right? Then coming to lab findings. So in the patients of insulinoma, there will be hypoglycemia along with hyperinsulinism, right? And there's a test called as 72-hour fasting test, which is done to diagnose insulinoma. What happens in this test is the patient will be in fasting state for 72 hours, and obviously after this fasting the blood glucose level of the person will fall, and in order to compensate that low blood glucose, the level of insulin should also fall. But this does not happens in the patients of insulinoma. This is the case of normal individual. So what happens in insulinoma is, despite of low blood glucose level, the insulin level will be high, so insulin glucose ratio will be high. And apart from that, as the insulin produced in case of insulinoma is produced in the form of proinsulin, and later this proinsulin is broken down into insulin and C peptide. So the level of C peptide will also rise. And apart from all this, we can also do imaging studies like CT and MRI in order to locate the nodule of insulinoma and find out the extent and size of the nodule, right? Then coming to the treatment part, so we have two options for the treatment of insulinoma. We will go for surgical management, in which we will simply do the surgical removal of the tumor, and it is the treatment of choice for insulinoma. But if the nodule is not operable, then we have to do medical management, which is done with the help of diazoxide like drugs, which are basically potassium channel openers, so they inhibit the release of insulin. Now coming to the IHC markers, that is immunohistochemical markers of insulinoma. So insulin will be a IHC marker, as it is a tumor of beta cells of islets. Then Ki67, which is basically a proliferation marker. Then as insulinoma is a neuroendocrine tumor, so synaptophysin and chromogranin A will also be will act as a IHC marker in case of insulinoma. Then coming to differential diagnosis of hypoglycemia. So if any patient is presenting to us with hypoglycemia, insulinoma can be one cause, and apart from that there can be many causes, which includes like abnormal insulin sensitivity. So if suppose a person is showing abnormal response, if it is showing exaggerated response to insulin, there is a risk of hypoglycemia, right? If any fibroma or fibrosarcoma is there, which is responsible for ectopic insulin production, so this high insulin will lead to hypoglycemia. If the patient is having any diffuse liver disease, again there will be complaint of hypoglycemia. And if the patient is on exogenous insulin or oral hypoglycemic agents like sulfonylureas, then also the patient can develop hypoglycemia. And this kind of hypoglycemia, which is basically due to administration of exogenous insulin or oral hypoglycemic agents, is called as factitious hypoglycemia. And it is very important to distinguish between factitious hypoglycemia and insulinoma. So as we already discussed, the level of C peptide is elevated in case of insulinoma. But if the patient is on exogenous insulin, the level of C peptide will not be elevated. So in this way, you can distinguish the hypoglycemia due to exogenous insulin, or it is due to insulinoma. And suppose if the patient is on sulfonylureas, in this case also basically sulfonylureas act as insulin secretagogues. So the level of proinsulin will increase in the patient again, and this will split into C peptide and insulin. So C peptide level will also increase if the patient is on sulfonylurea. So depending upon the C peptide, we cannot distinguish, right? So basically we go for sulfonylurea assay of urine, and now we can find out whether the hypoglycemia which has developed, it is due to sulfonylurea or it is due to insulinoma. So this is all about insulinoma and pancreatic neuroendocrine tumors. Thank you for watching.